if you believe you can do anything. In this video, I will cover abnormal uterine bleeding, commonly known as AUB. The old classification that described different types of menstrual abnormalities are not commonly used and are collectively referred to as abnormal uterine bleeding. It's important to understand that if the patient gives a history of abnormal uterine bleeding, it's important to treat them as such. There isn't an objective way to accurately assess the amount of blood loss. The severity can somehow be assessed by asking a few questions. For example, does the patient use double protection? Does the patient have any blood clots with the periods? Frequent change of a pad or a tampon? And history of blood transfusion. The causes can be divided into structural and non-structural. The structural causes include polyps, adenomyosis, leiomyoma or fibroid, and malignancy and hyperplasia. Non-structural causes include coagulopathy or bleeding disorder, ovulatory dysfunction like polycystic ovarian syndrome, endometrial pathology, iatrogenic, and not otherwise classified. Management starts by taking a history and performing clinical examination, including signs of anemia and a pelvic examination. At this stage, we can obtain a pap smear and swabs for infections. Other investigations include a pregnancy test and blood tests to check the hemoglobin level. And depending on the history and clinical suspicion, other tests should be considered, like thyroid function tests, liver function tests, and iron studies. Coagulopathy investigations have special circumstances and will be discussed in a different video. An ultrasound scan should be ordered if there is a suspicion of a mass or if the physical examination is not possible due to high BMI, for example. Obtaining an endometrial biopsy should be done if the patient is over the age of 45, if there is a history of PCOS, high BMI, or if the medical management has failed. Treatment starts by controlling the current episode if the bleeding is heavy and the patient is clinically unstable. This can be achieved by giving intravenous estrogen or by giving high-dose oral contraceptive pills. If the patient is clinically stable, you can skip this step and move to the long-term management. Long-term treatment can be divided into medical and surgical, but do not forget to treat the primary cause. Medical treatment includes inserting the levonorgestrel intrauterine device, combined oral contraceptive pills, or progestin oral or intramuscular. Surgical treatment includes uterine artery embolization, endometrial ablation, or a hysterectomy. If you want to support this channel, please like and subscribe. Click on the bell to be notified when a similar video is posted. Feel free to share and see you next time.